Welcome to the deep dive. Today, we're diving deep into endovascular diagnostics. Those amazing techniques where doctors diagnose and even treat vascular diseases from the inside out. It's often the first choice now, sometimes even preferred over traditional surgery.
It really is remarkable, isn't it? Highlights the ingenuity in modern medicine. Our goal today is to sort of unravel the core tools and methods that underpin this field.
Yeah, we want to give you a solid understanding of how clinicians figure out what's happening inside your blood vessels based on some key chapters from Rutherford's vascular surgery and endovascular therapy.
Exactly. Think of it as a guided tour. We'll start with the critical first step. How do doctors even get inside these vessels?
Right, vascular access. Then we'll trace their path using wires and catheters. And finally, look at the different diagnostic procedures they can perform. Okay, let's get right into it. Vascular access sounds simple enough, maybe.
Well, it's the fundamental starting point for pretty much every endovascular diagnostic procedure.
Makes sense.
It all begins with percutaneous access, which basically means getting into the arteries or veins through the skin.
And for arteries, I hear the common femoral artery, the CFA in the groin, is like the main entry point.
Overwhelmingly so, yeah. Especially when we're looking at the aorta, the iliac arteries, or down into the legs.
So why the CFA? What makes it such prime real estate for this?
Several key reasons, really. First, it's a decent-sized vessel, relatively large diameter, makes getting tools in a bit easier.
Okay.
Second, and this is crucial, it lies right over the medial part of the femoral head, that big bone in your hip joint,
Ah, okay. Why is that important?
because it gives you something solid to press against afterwards to stop bleeding.
Mm-hmm.
For hemostasis, super important.
Right, compression. Makes perfect sense.
Plus, it offers a pretty direct path up to the aorta and down the leg arteries.
So when clinicians are aiming for the CFA, what are the landmarks they're using? It's not like there's a literal road sign, is there?
Not quite. But there are reliable anatomical cues. The CFA essentially starts where the external iliac artery ducts under the inguinal ligament that crease in your groin.
Okay.
Just below that ligament, you'll find where smaller arteries branch off, like the superficial epigastric and circumflex iliac.
Gotcha.
Then the CFA runs down maybe 5 to 8 centimeters before it splits into the superficial and deep femoral arteries. And importantly, it's bundled in the femoral sheath with the femoral nerve on the outside and the femoral vein on the inside.
So it's a bit of a crowded neighborhood down there.
It is. You need to know your anatomy.
Oh,
And
yeah.
you mentioned the inguinal ligament and femoral head. We also use bony landmarks under fluoroscopy. That's like live x-ray.
Right.
You can see the femoral head clearly. And also the top point of your hip bone, the superior iliac spine, and the pubic tubercle. These help pinpoint where the CFA ends and the external iliac begins, basically above the inguinal ligament.
So people sometimes draw the ligament on the skin.
Yeah, some practitioners do that as a visual guide, especially when starting out or if the anatomy is tricky.
Now, you said the puncture location is critical. Getting it wrong can cause problems.
Oh, absolutely. Big problems. If you puncture too high, too cephalad, we say like above or through the inguinal ligament, you risk hitting the external iliac artery
And that's bad because...
because you can cause a retroperitoneal hematoma, bleeding behind the abdominal lining. That can be really serious, very hard to control with pressure.
Yikes. Okay. And too low.
Too low, meaning you hit the superficial femoral artery instead of the common femoral, increases the risk of things like pseudoaneurysms, false aneurysms, or an AV fistula, an abnormal connection to a vein, maybe involving the profunda femoris artery, or even tearing the lining of the artery, a dissection.
So precision is key. What about antegrade access? You mentioned that briefly, going down instead of up.
Right, antegrade means pointing the needle towards the foot. It's less common for just diagnosis, more for interventions further down the leg.
When might you choose that?
Maybe if someone has kissing iliac stents, which can make going up and over the bifurcation tricky from the other side. Antegrade keeps things in one plane, can give better push.
But it sounds harder.
It can be technically more demanding, yeah. You still puncture the CFA, usually a bit higher up, to get enough room to steer the wire down the superficial femoral, not the profunda. The needle angle is steeper, downwards.
And in larger patients.
Yeah, sometimes you need tape to retract excess skin or tissue, the pannus, just to get the right angle for the needle.
Okay, moving away from the leg, what about arm access? The brachial or axillary artery. When are those used?
Often when there's really bad blockage in the arterial arteries, making femoral access tough or impossible to get where you need to go.
Makes sense.
And they're also sometimes preferred for getting into the mesenteric or renal arteries. The angle coming down from the arm can actually be better for hooking into those vessels as they come off the aorta.
Let's talk axillary first. There was an older way of doing it.
Yeah, historically access was in the intramuscular groove between the triceps and coracobrachialis muscles. Arm out, bent.
Why did that fall out of favor?
Couple of reasons. Hard to compress effectively against the humerus to stop bleeding, and risk of nerve compression, the median nerve, if you got a hematoma in that tight space.
So now it's mostly brachial if you need arm access.
Pretty much. Though there's some interest in a newer, more proximal axillary approach, just below the collarbone, the infraclavicular approach.
Why that spot?
Well, theoretically, it's a larger vessel there, maybe allowing bigger sheaths like the CFA. Could be useful for complex procedures.
But there's always a but, isn't there?
Usually. The big but here is compression. You can't really compress it effectively if a closure device fails. And surgery to fix a problem there risks injuring the brachial plexus nerves. So it's still being evaluated carefully.
Okay, so a definite trade-off. What about brachial artery access itself, down by the elbow?
Exactly. You can usually feel the pulse right over the olecranon process, the bony point of the elbow with your palm up.
And how do you access it safely?
Ultrasound guidance is really common now, along with a micropuncture needle. The key is to aim for this spot over the medial epicondyle, that inner bony bump,
Why specifically?
because that's where you can compress the artery against the bone for hemostasis. And again, it's a tight compartment, so even a small bleed could compress nerves. Ultrasound helps get a clean, single puncture.
What size sheaths are typically used there?
Usually up to 6 or maybe 7 French is considered acceptable by most.
And common uses for brachial access?
You see a lot in cardiology for coronary work, setting up dialysis access, treating subclavian artery problems, sometimes for complex aortic aneurysm repairs, EVR. And like I said, accessing mesenteric vessels often works better from the arm because of the downward angle they come off the aorta, avoids that sharp U-turn from the leg.
Interesting. Okay, so we've hit the main two. What about some of those other arterial options you touched on? Popliteal, behind the knee.
Yeah, the popliteal artery, you can access it retrograde, going backwards up the leg. Used to be done sometimes to cross an SFA blockage.
But not so much anymore.
Not really. Pedal access going from the foot has largely replaced it. Compression behind the knee is really difficult, lots of fatty tissue, makes hemostasis unreliable.
And you need imaging.
Absolutely. Ultrasound is essential if you ever consider it, just to even tell the artery from the veins.
What about those arteries even further down, infrageniculate or pedal access?
Right, pedal access, gaining a lot of favor, actually, especially for tough blockages in the tibial arteries when you can't get through from above.
How's that done?
Almost always with ultrasound and micropuncture needles. Often you don't even put a sheath in, just work with the wires and catheters directly.
Which foot arteries are best?
The dorsalis pedis on top of the foot is great. Superficial, easy to compress. The posterior tibial behind the inner ankle bone is another good one. Palpable, compressible.
And the peroneal.
Rarely used for access. It's just too deep between the bones, hard to get to safely percutaneously.
Okay, what about going straight into the iliac artery? Seems direct.
It does. But percutaneous puncture, there is generally a no-no. Big risk.
Why is that?
Can't compress it manually if it bleeds. And lots of vital stuff nearby. If you need iliac access for large devices, like for aortic repairs, it's usually open surgery. Or sometimes they sew on a conduit, like a little tube, to puncture, or use endoconduits placed from the femoral artery.
Gotcha. Radial artery access in the wrist, you said that's getting more popular.
Very much so. Preferred by many cardiologists now, and increasingly for peripheral work, too.
Where exactly is it?
Over the radius bone and the distal forearm, usually easy to feel, easy to cannulate, often without ultrasound. Hemostasis is also pretty straightforward, compressing against the bone.
But there's a test you need to do first.
Crucial. Allen's test or some imaging to check the ulnar artery flow. You need to make sure the hand has good backup blood supply from the ulnar side in case the radial artery has a problem during or after the procedure.
What size access does it allow?
Typically accommodates sheaths up to about 6 French. So good for many procedures using smaller gear.
And last one for arteries. The common carotid in the neck. Sounds risky.
It is. Percutaneous access there just for diagnosis is rare. Too much risk of stroke from clots or just blood flow. And hemostasis is very tricky, dangerous to compress there.
So how do you access it endovascularly then?
Usually with long catheters or sheaths coming up from the femoral artery, or there's a hybrid technique, TCR transcarotid artery revascularization. That involves a small surgical cut down to expose the artery, then direct puncture under vision.
Okay, let's switch to veins. You said venous access kind of mirrors arterial, but with key differences?
Right. Hemostasis is usually easier because of the lower pressure and thinner walls. but getting access can sometimes be harder.
Why is that?
Veins can collapse when you try to puncture them. They don't have that same stiffness as arteries. Sometimes a through-and-through technique helps.
And they're less stretchy.
Yeah, they hold a lot of volume, but don't stretch like arteries. More prone to tearing if you use too large a sheath or device.
You mentioned using a syringe is critical for venous access.
Absolutely vital, especially in veins above the heart, like the internal jugular, IJV. Two reasons.
Okay.
First, gently pulling back creates a vacuum, confirms you're in the vein immediately when you see blood return. Second, it prevents sucking air into the system, which can cause a dangerous air embolism. Super important in veins like the IJV, where pressure can actually be negative.
Right. Air embolism. Okay, let's run through common venous sites. Common femoral vein.
Very common, just medial or inside to the CFA. Used a lot for procedures in the vena cava or its branches, like investigating pelvic congestion syndrome. Compresses easily against the femoral head.
Ultrasound useful?
Often used yet to make sure you hit the vein and not the artery right next door. You can also cross over to the other leg's veins from here, though navigating valves takes some skill.
What about the popliteal vein behind the knee?
Usually needs the patient lying face down, prone.
Yeah.
Interestingly, there are often two popliteal veins running with the artery.
And you need ultrasound.
Essential, really, especially if you're doing it for DVT diagnosis or treatment, because the vein itself might be clotted. Ultrasound lets you see the puncture and wire passage, even if you don't get blood return.
And the saphenous veins, the ones near the surface.
Great in small saphenous veins, often accessed for DVT or chronic venous insufficiency work. They're smaller, collapsible, so ultrasound is generally needed.
Can they take a decent sheath?
Most can handle at least a 6 French sheath. Accessing the top part of the small saphenous gives a nice route into the popliteal vein, sometimes used for delivering clot busters for femoral DVTs.
Moving up to the arm veins. Basilic? Cephalic?
Yeah, used for central venous stenosis, dialysis access issues, venous thoracic outlet syndrome.
Any preference?
For thoracic outlet, the basilic vein is often preferred. It connects deeper, unlike the cephalic, which stays more superficial. Basilic is usually single, less risk of hitting an artery or nerve compared to the brachial veins.
And using them for vein mapping before dialysis access.
Mostly replaced by duplex ultrasound now. Much easier and non-invasive.
Okay, the internal jugular vein, the IJV in the neck, big one.
Relatively accessible, yeah. Runs between the two heads of the sternocleidomastoid muscle, just lateral to the carotid arteries.
Ultrasound needed.
It's definitely the standard of care now. Minimizes the risk of hitting the carotid artery by mistake. The IJV can take large sheaths, used a lot for central lines, dialysis catheters, IVC filter retrievals.
And lastly, the subclavian vein under the collarbone.
Mostly used for central lines and pacemakers, rarely just for diagnosis. Access is usually lateral. The newer microconvex ultrasound probes have made guided access much safer there too, reducing risks to the artery and brachial plexus.
Okay, great overview of the sites. Now, the tools and techniques that help actually get into these vessels safely, what adjuncts are used?
We can break it down. Adjuncts, needles, and puncture techniques. For adjuncts, manual palpation is the classic way, feeling the pulse.
Can you tell much just by feel?
An experienced hand can, sometimes. A hard, calcified artery might feel different, roll into your fingers, compared to a healthy pulse. Usually use 2 fingers, insert the needle between them. Works okay in thin patients, clear anatomy.
But challenging if?
Challenging in obesity,
No.
or if there's significant disease upstream affecting the pulse.
So what else helps? Fluoroscopy.
Fluoro, the live X-ray, is helpful for relating the needle to the bony anatomy, especially in the groin, confirming you're aiming at the femoral head level, avoiding that dangerous hypuncture. It's like an X-ray landmark check.
But ultrasound seems like the real game changer for access.
Oh, absolutely. Direct, real-time visualization of the vessel, surrounding nerves, veins, plaque,
Yeah.
everything. Huge help in obese patients, diseased vessels, scarred groins.
And the evidence supports it.
Consistently. Studies show ultrasound guidance increases success rates and significantly reduces complications. You see the needle advance, indent the vessel wall, just takes the guesswork out.
What about the needles themselves, different types?
Mostly single wall needles now, usually 18 gauge for a standard 0.035-inch wire or a smaller 21 gauge for a 0.018-inch wire like in micropuncture.
What about double wall needles?
Mostly historical. Used to do a through-and-through puncture in the femoral, pull back till you got blood, caused unnecessary back wall trauma. A similar concept needle is still used for translumbar access sometimes, but you take the stylet out carefully.
And the techniques. Micropuncture is very common now, right?
It is probably the most common. Usually uses ultrasound, maybe fluoro too. You use that fine 21 gauge needle, shallow angle, 30-45 degrees.
Then what?
Get blood return, then carefully advance a thin, 0.018-inch floppy tip wire. Watch it on fluoro to make sure it's tracking. Okay, no dissection.
Needle out, then sheath.
Needle out. Then slide a small 4-French introducer sheath over that thin wire. Got to be gentle. The wire's flimsy. Sometimes rotate the sheath or pre-dilate if it's tough tissue. There are even sharp 4F sheaths now.
Okay, 4F sheath is in.
Right. Then inner cannula and .018 wire come out. Put in a standard .035-inch wire, often a J-tip for safety. Check fluoro again. Then exchange the 4F sheath for your working sheath, maybe 5 or 6 French, holding pressure.
And always aspirate and flush the side port.
Always. Get air out, prevent clots forming in the sheath. It's a meticulous process, but the smaller initial puncture often means fewer complications.
Makes sense. What about the standard needle technique? Still used.
Still an option, yeah. Especially if you've got good palpable pulses, straightforward anatomy.
How's it different?
Uses the larger 18-gauge needle for the first stick, then directly insert the .035-inch J-wire.
Yeah.
Skips the whole 4F sheath step.
Faster, cheaper maybe?
Can be. And actually, the larger needle and stiffer system can sometimes be an advantage in scarred groins, deep vessels, or even puncturing old Decker grass, where you need a bit more oomph.
Okay, so we're in the vessel, and now we need to navigate catheterization. Guide wires seem crucial here.
Absolutely. They're the pathfinders, the unsung heroes maybe, but gosh, there are so many options.
Yeah, it looks like a huge variety. What are the key things doctors consider when picking one?
It really boils down to a few key features. First, the tip. Is it soft and floppy for safety? Or stiffer, maybe angled, to steer through twists and turns or get into side branches?
Okay, tip design. What else?
Stiffness of the wire body itself. Steel core wires are generally stiffer, more supportive than nitinol wires, which are more flexible.
Diameter and length matter too, I assume.
Definitely. You hear about .035 or .038-inch wires. Those are standard large ones. Then smaller .014 or .018-inch ones. Lengths vary hugely, 120 up to 360 centimeters.
Why so long sometimes?
For exchange length. You need to put a long catheter way up into the body from, say, the groin. You need a wire long enough to stay in place while you swap catheters. But long wires can be unwieldy, slightly higher contamination risk.
And coatings.
Yeah, many have Teflon or hydrophilic coatings, makes them super slippery, reduces friction moving through vessels.
You mentioned a standard entry wire. What's that like?
Typically a steel wire, movable core, with a J-shaped tip. That J-tip is designed to be atraumatic, bounce gently off vessel walls, especially navigating the iliacs.
Why the J shape?
The rounded bend helps prevent it digging into the vessel wall, causing a dissection, or accidentally diving into small side branches when you're just trying to get basic access established. Good for quick, safe sheath exchanges, too.
So J-tips for starting. What about those floppy tip wires?
Very safe once you're inside the main vessels. Minimal risk of trauma.
But not good for steering.
Exactly. Too floppy to push through tight curves or actively select a side branch. For that, you need wires with stiffer tips, often angled tips, like a stiff angled glide wire.
How do those work?
The angle lets you direct the tip by rotating the wire from outside the body. You can carefully manipulate it to navigate tortuous paths or cannulate specific branches.
Requires careful watching, I imagine.
Constant fluoroscopic observation is critical. Watching the wire advance tells you if it's safe and can even give clues about blockages or other problems.
Any wires to avoid for initial entry?
Those hydrophilic coated ones, the super slippery ones, generally shouldn't use them for the very first pass through the needle. The coating can shear off, potentially embolize. Best used once a sheath is in place.
Okay, wires guide the way, then you need sheaths. What's their job exactly?
Sheaths maintain that access point you worked hard to get. They're like a protected tunnel or portal.
Portal 4.
For passing wires, catheters, balloons, stents, other devices in and out without repeatedly poking the vessel or losing your access.
What are their features?
They have a one-way valve at the hub to stop blood coming back out, a side port for flushing, injecting contrast, or drawing blood. They come in different lengths and diameters, measured in French size. 1 French is 0.33 millimeters.
What are common sizes?
For diagnostics, maybe 4 to 7 French usually, up to 11 French, or even much larger for big devices like aortic endographs.
And the valve helps with?
Hemostasis during exchanges, keeps blood in, and importantly, prevents air getting sucked in, especially on the venous side. Some are braided too.
Why braided?
Resists kinking, especially around corners. Provides a stiffer platform if you're pushing through tough tissue or making sharp turns. Many also have radiopaque markers near the tip.
For visibility.
Yeah, helps you see exactly where the tip is on fluoro, useful for positioning and even making measurements inside the vessel.
And sheath length, how do you choose that?
Depends entirely on the job. How far do you need to reach reliably? For many diagnostics, a short 10-centimeter sheath is fine. You use a longer catheter to get the contrast where it needs to go.
When would you need longer ones?
Maybe a 45-centimeter sheath to work on the opposite leg from your access point going up and over,
Mm-hmm.
or a 90-centimeter one to reach the aortic arch from the groin, or mesenteric vessels from the arm. Need that stable support.
So the rule is?
Use the shortest sheath that does the job adequately. Minimizes sheath-related issues.
Okay, access maintained. Now the diagnostic catheters themselves, delivering contrast.
That's their main job, yeah. Delivering contrast dye right where you need it for the angiogram pictures. And like wires, huge variety in size, length, tip shape.
What features do they have?
Often radiopaque markers, maybe hydrophilic coatings for slipperiness, sometimes braided walls for better torque control ability to twist and steer.
How are they sized?
By their outer diameter, also in French.
Yeah.
So a 5 French catheter fits nicely inside a 5 French sheath, which is sized by its inner diameter. Most range from 2 to 6 French.
Smaller ones exist.
Yeah, 2 or 3 French microcatheters,
Mm-hmm.
used for super selective work, like getting tiny embolic agents way out into small vessels.
How are diagnostic catheters categorized?
Broadly, you can group them as non-selective, selective, and crossing catheters.
Let's start with non-selective, like a pigtail.
Exactly. Omniflush or pigtail catheters are classic examples, designed for injecting a good volume of contrast into big vessels aorta, vena cava, usually used with a power injector.
Why the side holes?
They have multiple side holes near the tip.
Mm.
Helps disperse the contrast widely, evenly, reduces the jet effect you'd get from a single end hole, which could damage the vessel wall.
And the curve.
The curve also helps disperse contrast. And that pigtail shape is handy for hooking the other side, the contralateral iliac, after you've imaged the aorta.
Okay. Then selective catheters.
Right.
Branches.
Precisely. Shaped with specific curves to cannulate individual branch vessels coming off the main arteries for detailed imaging or intervention in that specific branch.
How do they differ from non-selective?
Usually just have a single hole at the very tip. So generally not for power injection. Too much force out of one hole could cause trauma.
Lots of shapes.
Tons. Single curves for shallow angle takeoffs, maybe less than 45 degrees. Like a Kumpe catheter for getting into the opposite iliac from the arm. Double curves for sharper, near 90-degree takeoffs. The renal double curve, or RDC, is classic for renal arteries.
Yeah.
And reverse curves, almost 180 degrees back on themselves, for vessels coming off at a steep angle, like the aortic arch vessels from a femoral approach. Simmons 1 and 2 are common examples.
Are those reverse curves hard to shape?
They can be, yeah. Especially in a small or diseased aorta. You usually form the curve down near the aortic valve or by hooking another vessel like the left subclavian. Simmons 1 has a shorter curve arm, sometimes easier to manage. Simmons 2 is longer, maybe better reach for right-sided vessels.
Are there easier options?
There are some self-forming reverse curve catheters, like the VTK. Negates the tricky manipulation, but often has a shorter sidearm.
We also heard about crossing catheters.
Right, these are built differently. Low profile, quite stiff, often with a tapered tip.
Designed for?
Getting through tight narrowings, stenoses, or even complete blockages. Mostly used for interventions, obviously, to cross the lesion before treating it.
But useful for diagnosis sometimes.
Can be, yeah. If the spot you need to image is beyond a really tough narrowing, a crossing catheter might be the only way to get there diagnostically.
And guiding catheters, how do they fit in?
Think of guiding catheters as basically sheaths, but with preformed tip shapes like selective catheters, different lengths, curves available.
What's the key difference?
They maintain a constant inner diameter all the way to the tip. This allows you to pass smaller catheters, wires, balloons, stent smoothly through them.
So mostly for interventions.
Primarily, yeah. They provide that stable, larger bore conduit right up to the target vessel. Less common for just diagnosis because they're bulkier than standard diagnostic catheters.
Okay, procedure done. Need to close the hole. Closure devices are common now.
Increasingly so. Designed to speed up hemostasis, get bleeding stopped faster than just holding manual pressure, can free up the room quicker.
Does it save time overall? Bed rest time?
Oh, that's the debate. While it reduces compression time, most patients still need several hours of bed rest afterwards. So the overall cost effectiveness is complex.
How do they work? Different types?
A range. Some deploy an extravascular plug like the MINX device using a polymer seal in the tissue tract. Others use a suture-based approach like the ProGlide, which puts a stitch right across the arteriotomy. Then there are anchor-based ones like AngioSeal, which uses an anchor inside the artery and a collagen sponge outside, kind of sandwiching the hole.
Are there limitations? Size? Vessel condition.
Definitely. Angioceal, for instance, needs a certain artery size, no heavy calcification, usually up to 8 French holes. Minx usually up to 6 French. Proglide typically up to 6 French too, though sometimes multiple are used off-label for bigger holes, like in Percutaneous Vardivar.
Are there risks with these devices?
There are potential risks, yes. A slightly increased risk of groin infection compared to manual compression, and rarely leg ischemia if the device misfires or causes a blockage, but they can significantly cut down hemostasis time. It's a balance.
Okay, let's shift to specific applications. How these tools are used for different areas. Seems like the approach varies a lot.
It really does. Depends on the vessel size, the blood flow rate, the pathway you need to take, how sensitive the organ is that the vessel supplies. Lots of factors influence the choice of catheter and how you inject contrast.
Let's start with a common one, abdominal aortography. Looking at the main artery in the belly. How's that done?
Usually femoral artery access. Position a multi-side hole flush catheter, like a pigtail, around the L2 level second lumbar vertebra. That ensures you see the renal artery origins well.
What view do you use?
Typically an AP view, front to back. Sometimes elevate the patient slightly. Want to see the whole abdominal aorta and down into the iliacs if possible?
Then what?
After the main run, pull the catheter back to the bifurcation, where the aorta splits, to see the distal iliacs and common femoral arteries better.
Can you get angled views?
Yes, oblique views are important for separating the iliac arteries. LAO left anterior oblique shows the right iliac best. RAO right anterior oblique for the left iliac.
How much contrast?
A standard injection might be, say, 15 millimolars per second of 50% contrast for a total of 30 millimoles. Using a power injector, maybe around 800 psi pressure.
What if you need to see higher up, the thoracic aorta?
Need a longer catheter, obviously. And for specific things like planning an aortic endograft, you might use a special marker pig catheter with measured marks on it for accurate sizing.
Okay, moving down to the legs. Extremity angiography.
First step is often that abdominal aortogram we just talked about. Get the overview. Then, 2 main ways to get detailed leg pictures.
Method 1.
Bolus chase angiography. Position the flush catheter at the bifurcation. Inject contrast, and then take a series of DSA images following the contrast down both legs as the table moves.
How much contrast for that?
Might do something like 8 millimels per second for a total of 80 millimel. It's quick, efficient.
But downsides?
Image quality can be variable. Differences in flow between legs, limited projection angles, contrast gets diluted further down. And if you need to repeat it, that's a lot more contrast and radiation.
So what's method 2 if you need better detail?
Selective catheterization. This involves guiding a catheter up and over the aortic bifurcation into the specific leg you want to image.
How do you get up and over?
Often use the tip of a pigtail or omni flush catheter, point it towards the opposite iliac, advance a wire down that side, then push the catheter over the wire into the external iliac or a CFA. Or use other shaped selective catheters.
Then you image that leg specifically.
Right. Position the catheter, then do multiple DSA runs, usually injecting contrast by hand at different levels, thigh, knee, calf, foot, to see each segment clearly.
What about imaging the leg you started from?
Often just injecting through the sheath already in the iliac is enough for the ipsilateral side.
Can you use a power injector for selective runs?
You can, but you have to reduce the rates and pressures way down. Advantage is the team can stand back from radiation. Disadvantage is you lose that ability to adjust the injection based on what you're seeing live.
What about kidneys and gut arteries? Renal and mesenteric angiography.
Often the standard AP abdominal aortogram is enough to see the renal artery origins, where stenosis usually occurs.
But for more detail or intervention?
Needs selective cannulation. Use a shaped catheter, like that RDC renal double curve, get it right into the renal artery opening, then hand injections, maybe different angles.
And mesenteric arteries, celiac, SMA.
Aortogram often needs a lateral view to see their origins well as they come off the front of the aorta. That acute angle makes them tricky to cannulate selectively from the leg sometimes.
It helps.
Curved catheters, special sheaths, or, often easier, access from the brachial artery in the arm. Avoids that sharp U-turn needed from the femoral approach, especially if you plan an intervention.
Carotid angiography, neck arteries supplying the brain. Sounds delicate.
It requires careful technique, absolutely. Step 1 is usually a non-selective aortic arch angiogram.
How's that done?
Femoral access again. Multi-side hole catheter in the ascending aorta. Power inject contrast, maybe 15 millisec for 30 milli total. Often use an LAO view to spread out the arch vessel origins.
Is that enough?
Often not detailed enough for the carotids themselves. Usually need selective branch vessel angiography, But you do the arch shot first.
Why first?
It's your right map. Shows the anatomy, but also crucially helps assess if it's safe to try selective cannulation. You look for disease at the origins that might break off, increase embolization risk.
What catheters do you use for selective arch work?
Because of the arch shape, you usually need those reverse curve catheters.
Yeah.
Like a Simmons 1 or 2, advance it into the arch over a wire.
Then you have to form the curve.
Right. Either down near the aortic root or by gently hooking the left subclavian or brachiocephalic artery. Once formed, slowly pull back to selectively engage the brachiocephalic or the left common carotid.
Simmons 1 versus 2.
Simmons 1 has a shorter side arm, sometimes easier to manipulate. Simmons 2 is longer, maybe better for reaching the right carotid or subclavian via the brachiocephalic.
Yeah.
There are also self-forming ones like the VTK.
Once you're in the carotid.
Carefully inject contrast, usually by hand or maybe a very low-pressure power injection if stable. Say 4 ml sec for 8 mmol total, get your images.
Is it harder with different arch types?
Yes, type 2 or 3 arches where branches come off earlier or steeper can be more challenging, might need catheters with more extreme curves. Meticulous wire and catheter handling is paramount throughout to avoid causing a stroke.
Okay, shifting gears. Fistulography for dialysis access.
Right. Used when a hemodialysis fistula or graft isn't working well, or a new fistula isn't maturing.
How do you access it?
Direct puncture of the fistula graft itself. Choose a spot that lets you see everything and potentially intervene. Pre-op ultrasound often gives clues to the problem area.
Is access hard?
Usually palpable during dialysis, but ultrasound helps for immature or failing ones. Often, just a small French microsheath is enough for diagnosis. Can upsize if needed for treatment like angioplasty.
How do you image inflow versus outflow?
Outflow veins are usually easy to see. Flow is brisk. For inflow arteries, you often need to temporarily compress the access site while injecting contrast to get it to flow backwards into the feeding artery.
And lastly, pelvic congestion syndrome venography.
Similar principles to arteriography, but venous. Access the common femoral vein. Do an initial venogram, look for contrast washout near the renal veins, suggesting reflux from gonadal veins.
Then selective work.
Use a shaped catheter and wire to cannulate the proximal ovarian vein, often on both sides. Inject contrast gently by hand, low pressure. These veins are thin. Can advance the catheter further down if needed to see the whole pelvic network better.
All right, we've seen how versatile these techniques are, but things can go wrong. Let's talk complications. Access site issues seem common.
They are definitely among the most frequent complications. Things like hematomas, the access vessel clotting off, thrombosis, bleeding requiring treatment, forming an AV fistula, or a pseudoaneurysm.
Does guidance help prevent these?
Yes, using fluoroscopy and especially ultrasound during access has significantly reduced these risks. But patients who are obese, have bad atherosclerosis, or are on blood thinners are still at higher risk.
Tell us more about hematomas.
Small ones under intact skin are usually managed just by watching them. Pseudoaneurysms, if the anatomy's right, can often be treated with ultrasound-guided thrombin injection to clot them off, or compression.
What if that doesn't work, or it's large?
Larger PSAs, say over 3 centimeters, shouldn't just be watched. If thrombin fails, surgical repair is usually needed and works well.
Retroperitoneal hemorrhage sounded really serious. How does that happen?
Usually from that high puncture hitting the external iliac above the inguinal ligament. You can't compress it effectively there. Closure devices are a no-go.
What happens then?
Patients can get unstable fast, often needs urgent surgery. If caught very early, maybe endovascular treatment from the other side, a covered stent, or balloon occlusion.
And AV fistulas at the access site?
Less common. Tend to happen with more distal punctures involving the SFA or profunda and nearby veins. Many are probably asymptomatic, close on their own.
What if they persist and cause symptoms?
Usually needs open surgical repair. Some attempts at using covered stents, but not standard practice yet.
Okay, beyond the entry point, what about problems caused by the wires or catheters navigating inside?
Yeah, mechanical injury to the vessel wall, perforation poking a hole, dissection tearing the layers of the wall, can lead to clots forming and embolizing downstream.
How to prevent that?
Constant fluoromonitoring as you advance is key. Choosing the right size and type of wire and catheter for the vessel, not forcing things. Being especially gentle in delicate areas like renal or mesenteric arteries.
What about super stiff wires?
Can be risky, especially if they have a sharp transition from floppy tip to stiff body. Rarely needed for just diagnosis. If used for intervention, better to advance them through a guiding catheter for protection.
How are dissections or perforations managed if they happen?
Significant dissections might need angioplasty or stenting. Perforations, or AV fistulas caused by the wire, might need a covered stent if causing major bleeding.
Embolization. It's breaking off.
Often tiny microemboli, hard to detect or treat. Larger chunks might need clot removal devices or clot-busting drugs.
Can catheters get knotted?
If advanced without a wire inside, yes, it can happen. If you can't unknot it with a wire, might need surgery to retrieve it.
And finally, systemic complications, affecting the whole body.
3 main areas: the iodinated contrast dye, anticoagulation drugs used, and radiation exposure.
Contrast issues, kidneys.
Contrast-induced nephropathy, CIN. Risk for patients with poor kidney function, minimized by using less contrast, ensuring good hydration. CO2 gas can be an alternative for big vessels in kidney disease, but not great for small leg vessels.
For allergies.
Can happen. Pre-treatment with antihistamines, steroids if known allergy.
Then radiation.
Always follow the ALARA principle, as low as reasonably achievable. Minimize exposure time and dose. Crucial for patient and staff safety.
Wow, that was a comprehensive journey through endovascular diagnostics. What are the absolute key takeaways, the core principles for success and safety?
I'd say it boils down to a few critical things. First, really careful selection of the right access vessel for the job and the patient. Second, smart use of adjuncts like ultrasound to make that access safer and more reliable. Third, picking the right wires and catheters, understanding your tools, is vital for getting the diagnosis and avoiding harm. Fourth, achieving good hemostasis afterwards, whether manually or with a device. And finally, just having a solid plan for each procedure, knowing the anatomy, mastering the tools, that's fundamental to safe and effective practice.
It really underscores the skill involved. This has been an incredibly insightful deep dive. Thinking about all these advancements in minimally invasive techniques and imaging, it makes you wonder, doesn't it? How might these approaches continue to evolve? Could they change vascular disease management even more? Maybe moving beyond just diagnosis and intervention as we know them now?
It's a fascinating question. The potential seems enormous.
Definitely something for us all to think about. Thank you so much for joining us on the deep dive.